name is David Watson. I'm an associate professor at the University of East Anglia, and I'm also one of the Eastern Arc champions. My theme is health and wellbeing, appropriately, hence I'm chairing this session. I won't be talking today, but I'm going to introduce our two speakers. There was originally going to be three speakers in this session, so if you've been sort of looking ahead to the conference, you might have noticed that our session has changed slightly. So we now only got two speakers, but they're very closely connected in terms of what they're going to talk about and their interests. And obviously, whilst we're going to sort of zoom in a bit more on health and social care systems in this session, I think some of the questions and some of the thoughts they might raise hopefully will follow on from that keynote we just had from George, which was really interesting. So we don't necessarily want to limit the conversations to formal health and social care systems, but what we mean in terms of supporting health and social care more generally within communities and within society. So we've got quite a lot of time for this session, and the speakers are going to speak probably for about 10 to 15 minutes. They might go a little bit over, but we can be quite generous because we've got lots of time. But that's only really one part of what the session is about. The whole conference really is about trying to connect people, build collaborations for potential research, or connect people so that academics can share their research with relevant people, or policymakers can commission academics to do more research and just have useful conversations, ideally. So Pinar is going to be our first speaker. She's a colleague of mine at Essex Business. Sorry, I did my PhD at Essex Business School, so I've fallen into old habits. At Norwich Business School at the University of East Anglia. And it may seem a little odd that we've got two people from a business school speaking in a session about health and wellbeing, but actually there's a lot of research that goes on in our business school that is very relevant to wellbeing. Much of my research is around workplace wellbeing, so if anyone's got any interest around that, then I'm very happy to speak to people as well. Myself and colleagues do work with NHS organisations quite closely on workplace wellbeing, but that's not a focus for today's talks. Pinar is an associate professor in accounting. She's also our wonderful PGR director, so she knows a little bit about the postgraduate researchers' wellbeing, which is another area of my research, but again, won't talk about that too much today. And she is an expert on, particularly on healthcare and public sector, performance management and sort of accounting, I suppose, accounting of that performance. Is that fair to say, Pinar? Yeah, I'll let you say a bit more when you introduce your talk. And then we've got Esme Wilcox, who is going to speak after Pinar, and she's an independent researcher and consultant, but she's worked extensively in local and central government, and is interested in messy social problems and helping people hopefully address those. And I think we could probably all agree there's plenty of those within the health and social care system if we don't see the whole thing as maybe a messy social problem potentially. So that's broadly what the session's going to be about. We've got, I think, an hour and a quarter, is that right, Victoria, in total? Yeah, so we've got plenty of time. I think you've both got some slides to go through. If there are sort of questions following on from the presentations, then there is time for that. Because we're a small room in a relatively, well, actually quite a big group, but we're in a small room, we're not going to use microphones, so hopefully everyone's happy to just raise their voice and we can all hear each other fine. If you've got questions following on from the presentations, feel free to ask those, but we've got plenty of space for a much wider kind of discussion afterwards. And yeah, those presentations are really there to kind of raise questions and see where the discussion leads, really. And as is not unusual, we're at a stage where the health and social care system has been reorganised. I think there's a major announcement this morning from the newly appointed health secretary, which I haven't followed that at all, but the problems of the health and social care system seem to kind of survive each reorganisation. So those are the kinds of things we're thinking about today. So I will hand over to Pinar now to do the first presentation, and then Esme will follow on. Okay, so hopefully that's all set up for you and working, Pinar, and thank you very much.
Excellent.
Okay, over to you.
Thank you very much for the introduction, Dave. As Dave said, I'm Pinar. I'm from Norwich Business School, as Dave is. And I worked before for Essex Business School as well. So I kind of do that too, that's right, yes. And thanks for your kind words. I've been studying and I've been researching health systems and change in this country and in other countries. Today, of course, my talk is heavily influenced by my past research and my past connections with the people in the system and the documents in the system. What I'd like to talk about is the newly established integrated care systems in National Health Service, and of course the boards that are an important part of that, integrated care boards. And my focus is around responsibilities and accountabilities. I hope that the talk will follow on naturally from the keynote. I was really pleased to hear that Professor Jules mentioned a lot the systems approach, inclusion approach, cooperation, and finding spaces for dialogue and develop this. So hopefully we will build on that in this session. I'll start by looking at the VT reports that was also mentioned in the morning, and we'll see talk a bit more about the VT report this afternoon, as you know. So poor health and its implications for coastal towns and therefore local budgets is the introduction. A little bit about what are these new systems, how they work, and how did they differ from previous systems. Because I obviously, when I did my research over the years, I researched CCGs, clinical care groups, and of course the PCTs before that. So we are aware that the system actually renewing itself through policy every 8 to 10 years. So that's not new. So let's look at what's different now. How do these groups or systems control their organization in terms of budget and in terms of resources? So how we will know whether they will be working as intended? What are the parameters for that? What are the issues to consider? I think those issues to consider at the end are the spaces for our creativity. That's how I see it. How hopefully we can work on these issues. They are question areas that we can develop further. Sorry, this is a little bit small, but first off, if you look at VT reports, this is just one table from that report. It's actually table 1. What it shows here, this is cardiovascular disease statistic, and it shows different groups of disease. Then it shows expected patients, and it shows the actual patients and the difference for the coastal towns. So what it tells us very clearly is that if you look at these groups, coastal excess is in between 17 to 20%. So when I look at this, because I think about resources, because I know that resources are allocated based on expected patients and then adjusted according to what actual was, I can easily see here that the allocated resources will not be sufficient. And it's very apparent. We don't need to do anything in the calculation. We can see that. What the resource manager should do is to show actuals and fight for the excess amount to be paid back, which is quite difficult. So this is a huge problem. And how will the new system deal with this problem? And this is an inherent problem, and it's not a new problem. There is new terminology every time when there is a change in the system. This is the new structure and the acronyms that I'll use in my talk. ICSs are integrated care systems, ICBs are integrated care boards, and ICPs are integrated care practices. So systems, boards, and practices. That's what we are looking at. So these are definitions. Maybe I can come back to these definitions instead of reading them out loud. What I'd like to show you, the change was from 240 small area-based care to 42 area-based, local area-based care. So the number has significantly reduced from 200 plus CCGs to 42 integrated care systems. And if we look at our region here, we have 6 of those systems looking after the whole region. And we are just there. And then I took one example, which is number 1 here. If you want to just visualize the system itself, this is Norfolk and Waveney, and the integrated care system includes all of these institutions, groups, individuals, and care-related parties under this system. Right? This is called integrated care system. So it includes county councils, of course. It includes district councils. It includes NHS trusts, GP providers, GP networks, health wellbeing partnerships, other partnerships, associations. 1.1 million people they will be looking after in this number 1 ICS. And it's expected that these people will work together, okay, to solve the problems of the population of 1.1 million. And how much money do they have? They have about 2 billion. So that gives you a rough estimate about each ICS and their budgets. So they will use these 2 billion, which we know from the beginning that it's not going to be enough to look after this population here. And within this system, there are subsystems, basically, for this to work. Integrated care boards are the purchasers of the service. So they will be allocating the fund to the providers. Providers are trusts and private sector companies and charities and other GP providers, obviously. And integrated care boards, they are also having regulatory power. So what I put here, this was before July 2022, and this is what is happening after July 2022. So the system is looking like it's being simplified. But the issue here is integrated care boards, who will be the new purchasers, they are also now regulators, but they will be purchasing the service together with purchasers from purchasers, because they will have collaboration with provider collaborators. So here, purchaser-provider split is blurred. That has happened before, and that's a common issue. Because this has been done with some logic, because some past research obviously says there are problems in this purchaser-provider split. What I want to say is there are problems in every configuration. That's inevitable. So every time, if we want to address the latest problems of the latest configuration, we are not solving the main problems. That's an issue that we can actually address together, hopefully. That's what I'm planning to propose, really, towards the end. So when this purchaser-provider split is blurred, so the boards are both purchasers and regulators, and service providers' trusts are both purchasers and providers, this is what happens. Providers become, of course, part of the purchasing system here. When trusts are both purchasers and providers, and when local authorities are also included in an ICS, then creates tension. So we have past research showing that this tension is a big one, and it actually stresses people. Things get done. That's not a problem, because the system continues to deliver. That cannot stop. However, it is very apparent that there are certain issues that can be tackled quite easily by people who are not directly involved in the system. So I will propose academics to some extent, but I don't know how, of course, you will react. So providers in this new system are being asked to take more role, okay? More ownership of this purchasing activity, more in control of their budget, but that's a big shift again compared to the previous system that was in place. I took this from a recent King's Fund report that gives you, again, an overview of what is happening. NHS England and care quality controlling what's happening in the sector at the top. So care boards who have the 2 billion, for example, for the number 1 ICS, has that 2 billion to purchase the services. They are working with providers to do that. But partnership includes, ICS partnership includes all of the community in the system, and they are responsible of meeting the expectations of that regional public in terms of health expectations and health needs. So this is a much broader network of operation and organization. This is more specific, more focused on the healthcare purchasing and control. At this stage, what I thought could also be useful to look at is to see the 3 layers of place, from smaller to larger population, neighborhood, place, and system level responsibilities basically lie for each of these organizations. There was a question again in the morning, so which level should the change be starting from? But this shows us that ICBs and ICSs work at all these 3 levels. However, they need a clear structure of relations and accountability communication links between those parties, so that everybody knows, kind of what the regional frame is, where we are working towards, what we want to achieve in the end. So I thought this could help in terms of our visualization of the new system. So the key aims, if we want to design a new system, we can look at the key aims. They want to improve the outcomes, ICSs. They want to tackle inequalities, enhancing productivity, and helping the NHS to support broader social and economic development. So these are taken from policy documents, okay? So if these are aims, then we can design our reporting and accountability relationships around those aims. Whether this is happening or not, we don't know, but these are obviously very complex reforms, and at the heart of this reform is encouraging collaboration and involvement and talking. So ICSs, therefore, when aiming to meet those policy targets, should not lose sight of local groups and local needs, so that they can bring that very small local area needs together with the medium level area needs and high level area needs in a framework, in a coherent system. Again, this is from policy documents, and I cannot see how this is going to work with all these 150, 200 different organizations in terms of systems thinking and how ICSs report that. So there is a little bit more information about ICBs in terms of boards, but in terms of care systems, we are lacking, I think, a bit of clarity. So I'll come back to that. As I said, this is the 3-tiered model. It's a new terminology, but I just want to emphasize that that's not completely new, because that's what CCGs, previous commissioning groups, were doing anyway. Yeah, that's what they were doing. Again, we wrote about this quite extensively. So they were trying to meet the aims of the small groups, medium level and high level, through different means and practices, and they had actually developed some CCGs, very good competencies in doing that in time, and that needs to be, of course, used as an existing capital to continue building on, hopefully, in a new system. Now, I want to move to the boards. So the system is the map that I showed you, yeah, with all these parties. But the boards are smaller entities. Boards have financial responsibilities. They have the accountability on their responsibility on their shoulders. And the membership is like a chair, chief executive, 3 members drawn from existing NHS trust in the region. Of course, GP practice and local authority. That's a bit similar to CCG board structure. There is emphasis on mental health representation this time around, but there is less emphasis on clinical involvement this time around, which was a key feature of the previous forms. That's another, perhaps, question. Yeah, they have discretion on additional members. They have to make sure that patients and public are involved in their decision making. When that much power is given to ICBs, and when they have so much responsibility legislatively, the question is, where is the power of the ICSs? Okay, so how are we going to make sure that the system works when the power and reporting responsibility rise with the board? So that's a huge question, and as Ms. Toll probably will allude a bit more on that I question. So when I look at policy documents about ICSs and how their success is going to be measured, I can see a lot of words, and a new commissioning regime will start apparently from December this year, because that's again my kind of focus area, the metrics that are being used for fund allocation. That's what I usually look at. So I'm looking forward to this new change. So, as I said, ICBs are accountable for the performance and reaching targets. ICSs, they have potential to nurture different forms of oversight to drive local activities, local improvement. ICSs will be in partnerships with local authorities. ICSs will need to use insight from local people, and the coming months, that's, I think, interesting for me. Document says the coming months will show us how this is going to take shape. So this is also a prominent feature of central government legislation. That's not new. It is not possible to design a perfect system which will fit every region, every jurisdiction. Always, central government system gives that freedom, flexibility to local, right? Always. There is a huge work to be done here, right? This at each ICS level, at each one of these 42, they need to work on that. And I know that Cambridge and Peterborough started to work on that. They need to design something which will work for their community. I am not sure if where this capacity is, if this capacity exists, and where that capacity is. I really wonder, and I am, looking forward to observe that. So, this is therefore the area for our creativity and for our collaboration to hopefully do something better to make a difference. With all this accumulated knowledge, this purchaser-provider split had happened, 20 years ago perhaps, I'm not sure, because previous forms were not working, they were split. Now there seems to be a blurring rearrangement between them. And my question is, lines of responsibility are not clear, purchasers are both providers, there are issues here, but there is a big potential to create what could work for the local area. For the local area, when I say local area, for each ICS, that's what I mean, for each 42 of those places. So how could we redesign what we want? Okay, my question. Could we come up with clear and simple lines of communication and reporting within our own region? Let's not complicate this. Let's put our aims according to what policy actually frames. We don't have to really do exactly what it says, but as long as we understand that we are making a difference in that area, let's do that. So I am also a little bit obsessed, of course, with budgetary control. When we start running a system where we know that resource is not going to be sufficient, how are we going to deal with that? So we got to improve that lots of negotiation skills, I believe, within the system. Although I'm not working myself in it, I observe some meetings from time to time. So ICBs, or the boards which have the money, the system with all the stakeholders, and the ICPs, these are three different forms of governance, okay? And I cannot see the clear responsibility points, especially in ICSs, for the whole system working together. Do they have a budget? So I'm asking. I can't see any budget. I can see lots of organizations. I can't see a budget. Okay. There is no budget, and there are lots of things that they are expected to do as an entity together. If they don't have a budget, they don't have a reporting mechanism. So if they don't have a reporting mechanism, how are we going to see that ICSs are working? Could we design something around that? Could we explore this a bit more? And who's the responsible person here? I think local communities and their involvement, I know it's highly emphasized, but the means to do that are not there. But the means to do that are not there doesn't mean that the regions cannot do that, because they have that freedom to design the ICS relationship, and the board can have a influence, because they're holding the power, influence on that design and come up with something which might work for the whole region itself. Again, the beauty of the legislation in this sort of circumstances is that it's not got clear from the center what needs to happen, but then that gives some sort of freedom and flexibility in your own region. If you can, if it is possible to bring sources together to design that. So purposeful integration of stakeholders, I think, essential. We've been saying that for over 10 years. They've written about it extensively. And academics, they don't ask for any resource from you when it comes to these sort of things. And could academics be part of this ICS? Could they also be considered as stakeholders? This is, of course, not mentioned at all in policy documents, but that ties in well with the morning talk. Why this is not happening, we don't know. Could this make a difference? And as I said, Cambridge and Peterborough, they started working on something with universities. And your views and comments or questions about that would be very welcome. I don't know how long I used, but
yeah, no, that's great. Thanks
that's,
very much.
I don't know what I'm happy to take questions or comments.
So, going into any sort of questions now, we've got plenty of time after Esme talks as well. Nesme will talk a bit more about a project where she's been actually researching experiences of care. So we'll get more of a kind of real sense of what's going on within the system, I suppose. So that will follow on. But yeah, happy to take questions, Pina.
Yeah, sure.
Yes,
Please.
Pina, thank you very much. My role until this summer was a non-exec director for a clinical commissioning group and STP before. So many of your questions are bang on there. I now work for the university. So what we're designing in our area within Kent is actually looking at the local organisations.
Yeah.
And I think that's where the creativity is and the linkage that is where we need to have across from the university. Because of the plethora of people involved at ICS, it's quite difficult. But I do think it's a missed opportunity for universities completely. I'm working with, I think they're called now health and care partnerships,
Yes.
rather than integrated. So we're working locally and thinking about whether we can give our thought leadership around that and research. So already, so I work for a school of pharmacy, we're already sort of identifying some research projects for our students to be able to do. So it's about those connections in and sort of from the ground upwards. But I mean, many of your questions are things that concerned us as non-execs for a while. But there is a lot of information behind the scenes about how they monitor and do things, but it's just not visible externally.
Yes, yes. So you feeling they are sufficient?
I don't know if sufficient is always right. I think the trouble is when you have competing priorities, as you will even more so across the board now, is how you make that spend. And sometimes you have to be brave.
Yes.
And the reason for going bigger again, like strategic health authorities, was couched within, actually we've got foundation trusts that are above budgets, are not again getting paid per case, etc. We need to change how we fund things and move the money around the system so that it's outside the hospitals within communities, so people stay well longer in their own homes. However, nobody wants to give up their money.
Yes.
So it's about how on earth we achieve that together, and it's a group thing. And hospitals are now coming out and doing work outside hospitals within the community and trying to maintain that finance in a different way. But the trouble is buildings, estates, and they still need to be maintained. So there's lots of other wicked problems underneath. Digital's part of it too.
Of course, yeah. Thanks very much. Yes, thanks very much for the comments. Definitely. I think that's a way of finding those new ways of communicating with each other and yeah, helping. Of course, we are not saying that we will be able to just solve the problems of the system, but rather than that, making those connections a bit stronger and maybe making it a bit more clearer for people actually who are in it, because they are, as you say, keep working on the delivery and bringing something out, because it has to happen. I totally see that, but at the same time, yeah, when you take a step back and see, you know, how ICS, the system, is working, I am thinking that we can do a bit more around it.
Well, there's no more resource, so they have to use it wisely.
Yes,
So,
absolutely. Thank
if we
you.
take maybe one or two more questions and then
Sure.
we can move on to those most questions. We'll obviously have a wider discussion, so we've got much more opportunity. So I think you first.
So I concur with some of the comments that have been made. I sit on an integrated care board, so I'm kind of one of the new ways of working.
Wow.
And I do think the thinking is probably more advanced than you're suggesting in some areas. I think one of the interesting parts is that sort of neighbourhood level is being tackled in different ways. So you alluded to being geographic, which it is, for example, in Essex, which is where I work. I've just come from a system in Northamptonshire where actually they're creating alliances around particular cohorts of patients. So I think there's going to be some really interesting research opportunities around which of those kinds of approaches is better. But I think one of the key things about the budget is you're right, the integrated care system per se, it's allocated a budget, but the budget is controlled by the board.
Of course, yes.
But it has, for the first time ever, a system control total. So So it's collectively working together, which is why they've broken down the barriers between the providers, which was a competitive market, and now having a more collaborative market. And I guess the point is, and being a Director of Public Health, I'm in favour of it, is if you're trying to say if for this population at a more local level has got X amount of money, prevention is typically cheaper than a cure, therefore how do we work collectively as a group of providers with input from our local communities, and I agree with you that bit's not sorted yet, but how do we make people better for longer, basically? And obviously that does allow your resource to go further. Your point about the base budget being inadequate for coastal areas though is still a significant issue, which I think we need to think more about how we lobby upwards to manage that.
Yes, exactly, because that will need to be explained by yourselves very strongly, so that you can cover your position. And Witty definitely report helps you with that, but a bit more database, data crunching and supporting your argument, I think would be needed to keep your position strong. Thank you very much.
So I think you had a question as well.
It's more an observation, a brief one, but thank you very much. It's really enlightening. And just seconding what colleagues are saying, I work here at University of Essex. We've been approached by Mid and South Essex ICS to think through what evaluation of their performance might look like going forward. And I think there seems to be a degree of autonomy and around procurement of services like research, related research. It may not be a consistent picture across the country, but that's the sense that we're picking up, that they're quite keen to engage with us, partly because we've worked with the guy who commissioned the research, I think, in a different setting, and those kind of legacy connections are quite important. But yeah, it does feel like there's a desire to understand what the measures should be and to formulate those with input from research and from HEIs. So hopefully there is a positive direction of travel.
Oh, that's excellent. That's good.
I mean, I echo a lot of the clarity that you're identifying as well.
Yes, absolutely. Of course, we are outsiders. I mean, we can never be as knowledgeable as the people in the system, and we can never see the problem from your perspective, but that's also an advantage for us. So we can take that, bird's eye view kind of, and we do research in various different health systems around the world, so we can draw on and put you in contact with others as well. But it's really fascinating and refreshing that you've got interest from that side. That's yeah. Thank you.
I probably should have said at the start actually, and people have done this very well so far, but it's very helpful when people say maybe who they are and where they come from, because one of the aims is obviously creating connections today, so it's good to know who people in the room are and who are asking questions. I think there's one more question, probably if it's a quick question, we've got time to take that, and then we can move on to this.
My name is Tassis, I'm a research fellow at the Institute of Public Health and Wellbeing here at the university. I just wanted to quickly stand on something that Professor Witty mentioned in the previous talk, where he mentioned that there was an out-migration of youth and in-migration of elderly people. Now, to me, it's good that there's a focus on local organizations, but at the same time, you could imagine that some of the health inequalities that you notice in coastal areas may be problems that have happened in other areas and then sort of went there. Now, obviously, there is a burden in that area as a result, but it could well be that a budget could be spent outside of that area to handle that problem. To use a medical analogy, let's say you have an unfortunate analogy. Let's say you have a cancer somewhere in the body and then it metastasizes to the bone. If you've got a bone council that is tasked with solving the bone metastasis, you could see how you still need to deal with that problem, but maybe money would be equally served addressing the original cancer. Otherwise, you're sort of perpetuating a situation where you're flooding money into the bone, but you're not really fixing the problem. And I do want, and you could see that perhaps the bone council might be reluctant to spend money in the kidney, so to speak. And as I thought, perhaps this is a role for academics to provide this link, that to provide the evidence that your budget would be well spent if you sort of collaborate with institutions outside of your local region. But at the same time, it's such a chicken and egg problem, because as academics we need to find funding, and if the funding comes from local organizations, then again we would have a hard case convincing local organizations that we would
Spend
like
it
to do that.
elsewhere.
So just some food for thought.
Yeah, absolutely. I think that comes back to the bird's eye view that academics can actually take, and you can idealize the system from the top. You can say this money would be better spent here rather than giving it, let's say, for the sake of the example, ICBs, let's put it there. Yes, but you need to put all the evidence together with that and try to influence policymakers at that point. I think mine is a bit more applied, and I'm trying to tackle problems of the current at the at the delivery level and at the managerial level more so. How these managers can achieve what they are really wanting to achieve and also meet their targets at the same time and be content with what they do. So that's a bit like that, but I totally agree. Academics have that freedom and luxury to have the best view that they choose to take towards the problems.
Okay, so we can leave it there and move on to
Thank
those
you.
questions. Yeah, no, I bet you were. Yeah.
Because I think what you really nicely said, so I didn't catch your name, but was something that and I just said, that in every configuration there's problems. You know, you're talking about the problems of kind of outside of a bounded system. So we have this new boundary of this system here in terms of the ICS, ICB configurations, but actually we can't stop connecting with other places in terms of thinking about how we solve those problems. So my focus is really about the kind of, alongside this, a lot of the structural stuff as a way of describing what Pina's talked about. My stuff is about the patterns of behaviour that underpin and work alongside that structural stuff, and really trying to think about what are the patterns of behaviour that we want to substitute with more fit for purpose patterns of behaviour through this opportunity of this configuration and this transition that we've got now. And I'm really thinking about the dilemmas and the tensions that we have around the imperfectness of the system that we've got. And I use that language carefully because I think quite often we get into oppositional positions around this, and that's really tough. And particularly when you're talking about the future of caring. I did some primary research with carers, and people are under stress, and that's really, and I've experienced a lot of trauma. So So thinking about the language that we use. So the future of caring was a piece of work that was mentioned this morning with the Norwich Good Economy Commission, and it was an opportunity to, again, what Jules was saying this morning about the lack of imagination, having an opportunity to rethink with imagination what alternative socio-economic systems we might want. And really in the context of caring, saying that places, so Norwich, not the coast, but places that are, that we have been designed around an economic system that's designed around a 1970s problem of growth and productivity, and actually the problems that we're facing now are much more around how do we organise ourselves around energy, climate change and caring, I would posit. As these are the challenges that we really need to think about in terms of our models of organising in places. So I will talk about that project, but I also want to talk about the learning from other places as well around the patterns of behaviour around our ways of organising healthcare systems. And before I do that, I just want to warm us up with Pakefield Beach, which is where I started my working life. We've talked about CFAS this morning, so I was about 50, I think it might be 15 years ago now, I was supporting CFAS to think about its relationship with central government and its future, and how it changes its relationship from a purely public sector model of funding to a more commercial model, And I use this example not to give you a list of what's on my CV, but for me, coming into a place, being in a place and being in an office, and working with people where you've got on the one hand these phenomenal global research scientists and Fisher people trying to work together to tackle some of these big questions about the future identity of the organisation and how we organise towards that. But I had a wonderful view of Pakefield, and if we're talking about opportunities of the sea, you can't forget this fabulous ship, which since I was on it has now been looking if there's any seafarers people to give me an up-to-date point of view, but I understand it's going much further afield and doing some fantastic research. So this is a really important, to me, symbol and identity of Lowestoft and the opportunities of the sea. So the first point I want to make in terms of our the way we think about how we connect and engage in our healthcare systems and our economies and talk to people. So the Whitty report talks about the problem of what's on the periphery and what we notice, and how it is harder for us. There is a pattern of behaviour around not noticing what's on the periphery in terms of coastal communities and in terms of the aggregation of our data, and how quite often, I think Jules was talking this morning about Beccles, in terms of masking the affluence of Beccles, masking the poverty of Lowestoft and some of our other coastal communities. And so 11 years ago, Suffolk Community Foundation commissioned a report from the University of Cambridge called Hidden Needs. I don't know if any of you are involved in it or remember it, but it was really interesting, because at that time, for Suffolk, as a county which comes up quite well in terms of quality of life and wealth, these tiny pockets of rural poverty were the things that got missed. And it was those pockets that were, that was really political when that came out 11 years ago. Having the conversations about, you as politicians don't know your own communities because you've missed that there's this poverty here, and we don't understand how to engage with it or deal with it in policy terms. So this was, it's not a very clever image. It's trying to say it's a bit of a helicopter view, and what's the stuff that we miss. I think it's both on that level of what Whitty and Jules was saying this morning about kind of what's on the periphery. It's that mindset, our tendency to think about things that are that conform to a midpoint, because it's problematic to think about the diversity and the range and the complexity. But also in the context of a structure that we're talking about, we sit within our systems, our tribes, our organisations, and our natural linkages and networks are within those boundaries of our communities and our tribes. And you get this sort of argument, this oppositional argument about, oh God, you policymakers just need to go out and talk to people in communities. You need to be a bit more VCSE, you need to be a bit more. But it's not that simplistic. It's about how all of us can operate and connect across all of those different layers and different networks. And I'm positing this as a dilemma and a tension. I'm not saying that there is, I've got in my box of tricks an answer to this, but I think it is something that we need to think about more. It's not an either or, it's how do we reconfigure our relationships, our connections, our networks to be able to hear and for the communication to flow across all of those different layers, because the problems that we are facing, these really significant problems with opportunities, are not going to be solved from within our current modes of organising and our current networks and connections. So the Norwich Good Economy Commission. So this was a fantastic opportunity to rethink in a place. So we're talking about place-based approaches, saying Norwich is a size of place where we have got some agency and influence. Yes, a whole load of stuff when it comes to the economy is national, but we have influence locally. How can we imagine what a better economy looks like as a first step towards action? And my project, The Future of Caring, was really saying, we don't talk to, carers are on the margins. We don't talk to them in a way that imagines a different future, and as individuals under stress, because the system, there's talked about not enough money in the system, people under stress are it's hard to have imagination when you're under stress. So the first step was to build a bit of trust, to be let in, because let's face it, people are over-consulted and disappointed with the ways that we engage with them, and that's real. And who am I to come on as an independent researcher? You're still, an instrument of the state. So, conversations, to be let in, to hear the stories, to experience the reality of life as a carer, and then rethink what would it look like if we valued caring more, if caring was a design principle for how we organise ourselves and our economy. So we did that, we had some conversations in January, and I guess there's we talked a lot about connections. We talked a lot, Jules was talking a lot about social capital and agency, and I have to say it was pretty harrowing listening to people. It was. People have experienced a lot of trauma in the system, and this picture is trying to say the connections are broken. The connections that allow us to reimagine, the connections that allow us to be well are broken, but they're broken on a number of levels. They're broken on the level of the way our civic spaces are designed for throughput and not time to think about other people. And people were talking about the stigma of disability, and people are much more visible, but actually there's still it's still real in terms of our education systems and our inclusion of people. Connections are not there in terms of economic inclusion. So I think I spoke to 16 carers, and one of them we could just about say was doing something that I qualified for, because this is this is really current, 4-day working week and flexibility on our work. It's really current, but there's a big issue about carers maintaining their involvement in the workforce. So you will know this stuff. This is not new, but it's really important that we recognise this is what's going on in the system at the moment. And the third thing, and I am, I'm very careful about how I describe this, but the connections between individuals using services in the care system and caregivers are broken for a number of different reasons, but primarily because the system is under stress. We have a system which is not resourced sufficiently for the needs that people think they have, and we're constantly in kind of oppositional positions around in that system. So the connections are broken. I'm saying the connections are really important because we have so much research out there now about community well-being, about well-being that's around being connected, our sense of belonging and identity, the connection to place and our agency, our ability to organise around the problems that we face. And imagining a future where we are more connected, we are more able to be self-organised, we are able to respond to the issues, the problematic issues in front of us. The connections amongst the different layers are there, and the flow of information is possible, and we're able to conceive of and respond to the problems that we face. So this is the classic complexity kind of picture of the way that birds adapt and respond, and in a kind of unpredictable way, but highly connected, responsive way. What's next? feels a little bit like this at the moment. It feels absolutely terrifying in the terms of the real issues that we're describing, whether it's there was a question this morning about scaling. How on earth do we scale this stuff? It's dependent on kind of one individual with agency and then the conditions being there. It's dependent on sort of very localised emergent properties, and yet the scale of what we face is enormous and real. But this, to me, there's something here also about holding that space of transition. We've got these big structural changes that happen, but actually our space for learning and considering these dilemmas and tensions around our behaviour, that's really important. I think that's really important, that we give ourselves the opportunity to recognise these patterns in how we connect with each other, in how we organise, the tendency towards these oppositional positions, and really thinking about how do we use our power in these places, in these spaces, to notice what's on the periphery. What are the patterns of behaviour that we want to substitute for more cohesive, more collaborative patterns that enable us to confront and address and tackle some of these challenges, and really how do we hold some of that space to learn, to experiment, and that language of experimentation is problematic, I know, but how do we hold some of that learning space whilst we're still in this transition and before everything's been kind of pinned down, and address many of the challenges that Pinar's raised this morning in terms of that accountability and connections and that blurring and the stress and tensions within the way we structure and think about our patterns of behaviour underneath that. I think that's me.
Thank you very much.
Thank you.
We're all experiencing that.
I all may be experiencing it. Might get slightly dizzy, might need to move it, but.
So I might just see if we can move a few chairs around so that we're not all turning around to face the audience. That's all right. Pina, did you want to come back up?
Yeah, sure.
Are there any sort of specific questions for the resume in the meantime? Otherwise, we can also come back to some of those questions that were raised in response to Pina's presentation.
Thank you very much. I just wanted to kind of an example. You mentioned rebuilding communication between carers and systems. Is there an example of how, or does anybody have an example of how any particular initiative has tried to do that, or any learnings about doing that?
So let me talk about some work I'm doing in Norfolk at the moment, which is not only carers, it's carers and disabled people. So it's come back. So it's come on the back of being in legal proceedings between the council and a group and a disabled person, but the council recognising that it needs to rebuild relationships, and I think at its basic level, it's about putting people together in a space where we're working on the relationships as much as the outcome. So it's that basic stuff about being in a space with people where you're conscious of the power dynamics and the default modes of operating that people have that are not, and this is on all sides. This is not just ones which have traditional sources of power. This is on everybody in the room, thinking consciously about their modes of operating and how do we work towards a mode which is more collaborative and cohesive, and what is it that we have got agency over, and because there is a whole load that we can do together, even if there's a whole load of stuff that we over here which we can't fix. So I think that intention around, and the intention from the funders to see it through, rather than just say, well, that's been 18 months since we were in court together, so it must be fixed.
Thank you.
I just sort of abusing my role as chair slightly, I wanted to come back to some of the things that were raised earlier and just maybe ask a couple of questions to the room really and see what people's responses are. Partly based on this morning's session with Jules and some of the questions that provoked. And then again in this session, we've kind of come back a couple of times to this question of what the role is for universities or for academics within this space. And a couple of people within the room shared quite positive experiences of working with some of the partners in these new integrated care systems and the different institutional infrastructure that goes with that. So, I mean, I wondered maybe partly based on what people have said, is there what's the learning from those examples where people are working with higher education institutions or academics? How was that achieved? Someone mentioned, I think, Dorian, you mentioned kind of legacy of personal connections, which often it can be something like that, but lots of the questions that have been posed in the two talks are around kind of organisational questions of, you know, and it's a recurring question for the health and social care system because it's constantly being reorganised. And the question is, you know, what does this latest reiteration, what kind of opportunities does it give that maybe the last configuration didn't give? And where are the sort of opportunities for academics to really inform that helpfully and sort of act as, I mean, I don't think anyone mentioned it in here yet this morning, but I think it was mentioned by Anthony Forster. There's a new initiative of civic universities, and both the UEA, University of Essex, are civic universities. And at the moment, the UEA is trying to understand what that means. But so in this context, what would a civic university be doing as a kind of stakeholder within this? So that's that's a very broad question. But I'd be really interested to hear from people outside of academic institutions what they think and how you could kind of maximise. You know, as Pinar says, we don't necessarily work for free, but we do have resources to produce research, and we are interested in our research having an impact. So there's very good reasons for us as academics to work with local authorities and health authorities, and it's just trying to work out what really kind of drives those relationships successfully, I think is a key question. Yep.
So I'm Jonathan, so I am sitting in an academic post at UEA, but
yep.
I spent sort of 30 plus years in the NHS, and I suppose there's something for me, you know, sort of, I think it is quite stark when you see the map of the system and there's no HEI in that. And that says something to me about how the system actually perceives the role of HEIs and how we also perceive our role as being part of the system to work with and be an integral partner, because the future, the ICS structure is absolutely about collaborative working. And to do that, it's great that we develop personal sort of working relationships with individuals, but it feels to me there needs to be something more concrete than that, because people move jobs, and then those relationships go. So something about how we can add real value to the new emerging systems. I think there's a real opportunity, and I'm saying this to colleagues in the system I'm working in, is we have a blank sheet of paper. We can design what this really looks like, how working collaboratively will really add value to what it is we're doing. Having been through various NHS reorganisations, from strategic health authorities to PCGs to PCTs to CCGs, and now the latest iteration, structures are really important, but I think we're missing the opportunity about really looking at outcomes, because we could spend a lifetime just immersed in a structure. And structures are important and governance is really important, but perhaps we need to recalibrate the dialogue so that we don't at times feel that we're just on this sort of revolving hamster wheel of consulting with people, gathering information, saying this is really interesting, and then in the next iteration going back and doing the same. Because people want to see outcomes.
Yeah.
You know, if as a member of a community, if I'm asked my views and it goes into a research report, that's great. And actually I want to know what happens, what are the actions from that, so that next time someone comes and asks me for my view, I'm not telling them exactly the same thing. So there's something about us perhaps recalibrating those dialogues, and I think around embedded research as well. I think there's absolutely a place for the helicopter view, but actually there's a fundamental place for us to actually get alongside people to grapple with that complexity of the real world. Sorry, it's just lots of thoughts.
No, that's great. I mean, more thoughts are welcome, and I don't know whether our speakers want to respond.
Say, I think that's a really good question. What would a civic university do? Because it has the longevity. Talk about anchor institutions. So you're talking about a model of dialogue, which has longevity, because it's got to deal with the problem of the low level of the starting point around imagination, and the skill in engaging in your imagination requires a level of involvement and commitment and education and skill, and you know, at the moment, because it is problematic to get imaginative, future-focused questions and deliberation with communities, we design it as quite an intellectual pursuit when actually it's a creative kind of making pursuit. But because we don't have a mental model of how to do that, we default to not doing that, and it takes quite a lot of resource and support and imagination from the funders and the commissioners and the deliverers of it to do it. And that, I think, where you know, really speaking to what Jules was saying this morning, that's, you know, you can imagine universities getting hold of that within their remit as civic universities. But it's you know, we see you know, Jules had the picture of the kind of constant reports around coastal communities. We see it constantly with you know, engagement with Lowestoft from Ipswich, where the centre of local government is. It's really episodic, and no wonder communities get frustrated by it, and then you lose your social and cultural capital to continue doing it. So short answer, it is problematic. We need to do dialogue, we need to do it in imaginative ways, and we need civic universities to help support that, because you're in place for the long term.
Yes, I totally agree, but to the point about academic work, I think, John, your comments, very, very well said. We should do some sort of self-criticism here of academic work. Academics can produce work and can produce a lot of work, which they did, of the systems which were not working. So criticizing what's been happening and finding data and working on it is, or has been, a way for academics to deliver the message. But this is now changing, because the current academic view, as you also, I am sure, know very well as part of this institution, is that the civic university, working with practice, going into the problems and delivering some solutions in terms of joint outcomes, I think that's how we work these days. So we need to really work on changing the old image of academic work. That's why HE wasn't, I guess, involved or included in any of these configurations. But this is changing as far as we are concerned. It could be, as again Jill said, personal agency, but we have several academics doing that. So I think we need to work on it more. Absolutely right. And that's a fascinating part of our work, actually.
Just a couple of minutes.
Okay. Oh, right. Okay. So okay, we're running quite close to time, but obviously there's the lunch break as well. People can continue these conversations. Did you want to come in? Sorry. Yeah.
Yeah, is there time?
Yeah, sure. I mean, as long as people aren't really hungry, that's fine.
I'll try not to derail us too much.
Yeah.
So my name is Steph, and I run University of Essex, and I work as a knowledge exchange manager, and I have the least expertise in the room in this
my remit is the digital, creative and cultural sectors. But I guess I wanted to kind of pick up on the thoughts of the role of HEIs in this area, and also the theme of imagination that keeps running through a lot of our conversations and talks. And this idea of, what would it look like if, is something that we're asking all sorts of people, trying to engage all sorts of people with, which is actually quite a challenging thing, I think, to facilitate. And for me, it's kind of sparked the questions about who is good with those types of questions. What would it look like if? And a lot of that expertise, I think, can sit with the creative and cultural academics as well as sectors. And there's a lot of expertise there in how to broker access to that imaginative space, particularly, like you said, for people who may have kind of under stress, trauma. It can actually be quite also therapeutic in a way process for them, and we have a lot of expertise, I think, within those sectors and within our academic disciplines in those areas. We have a lot of creative practitioners in universities and people undertaking practice as research, as well as creative practitioners in HEI spaces. And I guess I see maybe there being a role of benefit to working with HEIs is that we have those disciplines under one roof, if that makes sense. And Dorian and myself and colleagues who are working in similar areas in similar institutions, our job is to try to sort of bring that together in a way. So I suppose for me, I'm wondering, do you see there being a role for greater kind of cross-discipline approaches to this? And is that something that you've kind of explored already, or is that quite new? Because I think it's new for, Arts Council have approached us because they're interested in our Institute of Public Health and Wellbeing, which is fascinating. I've never had that conversation with them before. And Arts and Humanities Research Council have recently launched a huge grant with a wellbeing focus, and that's not something I've seen them do before. So I'm seeing this kind of shift in a way, that arts is sometimes being seen as a tool as well, a route maybe to support areas of research like this. And I wonder if that's something you're already engaged in or you're interested in.
Yeah, it's quite a big question, isn't it? Because we're very short on time. I think you're right in terms of the way the discourse around wellbeing is sort of spreading into areas like arts in a way that it hasn't done previously. I know here at Essex there's a group, that works on green exercise and nature connectedness in terms of wellbeing as well. And I mentioned that I work in predominantly workplace wellbeing. If employers are doing things, are good employers, then you're also preventing a lot of the problems that the NHS is dealing with. So an integrated care system, health and care system, should be kind of taking stock of all of these things. So I very much agree in terms of interdisciplinarity. I think different academics working across with other stakeholders from different areas, but also individual academics themselves, not boxing themselves into disciplinary sort of niches, which ivory tower academic, that's the classic kind of, I'm an expert in this, but I wouldn't be able to. I think we as academics should be more open-minded as to where our expertise might lead us as well. Would be my reflection, but
and I think that mirrors the point I was making about organisations and partnerships at the start. That it's the tendency to become this sort of purist, when actually we need polymaths. We need people we need people who are able to connect across different levels and layers and networks. So absolutely, would love to talk more because it sounds amazing. It's a fantastic opportunity.
I don't want to stand between people and their lunch. It's been a really interesting conversation and hopefully fruitful. Obviously, remember all of the delegates' details are in the information packs, and I gave a bit of an intro for the speakers, but their bios and mine are all on the website. So if you want to find out more or reach out afterwards, then please do, and connect with each other as well. So thanks for your participation. And